As you all know, prostate cancer is a growing problem among men. It's one of the main cancers that men are affected by. In general, the prostate is about the size of a plum to about the size of an orange. It's about the milliliters in volume. And its role essentially is to help with ejaculation. It produces a fair amount of the seminal fluid, and that helps basically nourish sperm and helps liquefy it and get it out of the prostate. Let's go to the next slide. So, as you know, the prostate is in a bit of a precarious place when we think about treatment. It's right under the bladder, it's near the base of the penis, and it's also just behind it you have the rectum. There's also basically the vas deferens, which is basically a tube which allows sperm to get towards the prostate, and then the seminal vesicle also produces part of the liquid which constitutes the ejaculate. When we have prostate cancer, what happens is the cells which line the gland start having problems. There's different things which can induce damage to the cancer cell, to normal cells, and basically turn them into cancer cells. You can have basically sometimes what you eat. It can be random mutations. Sometimes it could be genetic predispositions, but all of this eventually leads to damage in the DNA of the cells, and those cells start behaving abnormally. They can take on a different abnormal shapes, and eventually they can become a malignancy, which is cancer. Once the cell has had enough damage that it has become a cancer cell, those cells will then tend to divide. They lose the normal control that the surrounding prostate and the normal tissue around would keep. And as the cells divide, they can become more aggressive. They can get outside of the prostate, and they can go to other areas within the body. In terms of the prostate itself, they can tend to form a mass, and that's something that initially it can be very small, so you don't always know it when it starts, but then later on, if it starts pushing on other structures, you can start having symptoms. So these are slightly older statistics from 2020. So prostate cancer is the fourth most common cancer in Canada. 1 in 9 men are thought to be diagnosed in their lifetime, and that might have increased over time. It's the #1 cancer in men, excluding skin cancers, and it occurs mostly in men over the age of 50. So in terms of statistics, currently in 2022, about 20% of all cancers amongst men are thought to be prostate cancers, whereas 10% of deaths to prostate cancer, attributable to cancer, originate from prostate cancer. When you start, so prostate cancer sometimes can be insidious, where most men, often when it's detected, have no symptoms. When it's detected early on, the main symptoms are urinary. You can have need to pee. The urge to pee can be greater. You can feel like having to wake up more often at night to pee as well. In terms of the stream can be weaker as well, and the stream can be intermittent when you pee. You can also sometimes feel like you're not emptying and have to feel the need to go to the bathroom repeatedly without emptying. When prostate cancer is more advanced, it can present with more systemic symptoms, such as weight loss, bone pain, sometimes even neurological deficits, back pain. We could go to the next one. In terms of work, blood tests for PSA, and usually just a rectal exam, see if they can feel anything. Now, the PSA usually rises when you have a prostate cancer, and what is in a normal value can depend on age as well. Generally, when you're older, the PSA, which is considered normal, can be a bit higher. So that's something to keep in mind. Now, once if the PSA is rising, or if there's some abnormality on the digital rectal exam, then at this point, usually your GP will refer you to the urologist. They'll ask for a biopsy. Usually, or historically, we've mostly done transrectal ultrasound-guided biopsies, the one on the left. And it's not very pleasant in general. And also presents some risk because we're putting needles through the rectum into the prostate, so sometimes you can get infections. I think lately they've been trying to move towards transperineal biopsies, basically, which comes more anterior in the area which is kind of below the scrotum and above the anus. So that has been a recent change. Also, what they've also been trying to integrate more MRI-guided biopsies. The benefit of that is you can see areas which are more at risk of containing prostate cancer and target those with additional needles. Whereas before, you just basically do a systematic biopsy where you try to put needles throughout the prostate and try to sample everything to get the best idea of what is in the prostate. Once you've had that biopsy done, basically it goes to another doctor, the pathologist, who looks at everything under a microscope, and they basically compare what the cohorts look like. And the Gleason score basically is a scale which looks at how normal the prostate cancer cells are. Scale, the more the tissue and the cells look like normal prostate tissue, and the further down when you have, say, a Gleason, when you're towards the score of pattern 5, the cells are more abnormal. So whenever they take a core, usually it combines 2 samples. So usually when you get a result, it's between a Gleason 6 and a Gleason 10 for the risk. And when they look at that under the microscope, basically, the cells that they see is something like this. They see abnormalities in the glands, which initially, when the tissue is more benign, it looks more like normal prostate tissue, whereas once it's more malignant, it looks as sheets of abnormal cells. So once you've had an initial workup with basically PSA, the doctor has felt the prostate, and maybe you've had an MRI and sometimes other staging scans. They basically determine in what group or how advanced the prostate cancer is. One way to look at it is the TNM staging, which stands for tumor, nodes, and metastases. So often what we look at on the digital rectal exam is the T stage to see if the cancer is limited to the prostate. If we can't feel anything, that's probably a T1. If it's confined to the prostate, it's a T2. If it starts going outside of the prostate or into the seminal vesicles, it's a T3. And if it goes beyond into other organs like the rectum or the bladder, then it's a T4. And basically, this is part of the staging, and we use this information in conjunction with the PSA and the Gleason score to put you in a risk category or to stratify you per risk. So if we could go to the next. And so this is a bit how it would look. So this is basically what we call a sagittal view when we're looking at a slice of you laterally. So stage one, basically, we don't see anything, or we see very little cancer, and we can't actually feel that. We might see something on an MRI. Stage two, it's a bit larger, and then we can start feeling a lump. Stage three, it starts going outside of the prostatic capsule. It can go into the seminal vesicles. And stage four, so it's T4, it's fairly extensive around the prostate. And in this category, you could also have disease which has spread to the lymph nodes or which has spread distantly in the body. So these are just pictures to kind of help visualize that. So it's basically the same thing to give an idea of the extent. All this information basically goes into risk stratification, and mostly it goes into a low, intermediate, or high risk group. And once you're in those groups, that's how we decide how to treat, depending on the information we've gotten so far. If your cancer is presumed to be at a higher risk, usually once it's in the intermediate category with bad features, or in the high risk category, we usually ask for additional staging scans, such as a bone scan, a CT scan, and now you probably get that MRI already done when they do biopsy. And as a doctor, what that helps us do is to see if there's cancer elsewhere. So, for example, this is a bone scan. So when you have, there's some things which are supposed to light up, like the bladder, which is the big dot in the middle, but all the other dots which literally light up, are cancer in the bone. So once we have that information, it changes how we would treat. And like in this situation, it would be completely different because we're no longer dealing with a localized stage. So this is a CT scan. Basically the thing in the middle is the prostate. And the CT scans are useful to see disease, but we don't see the prostate as well as we would see it on an MRI. What it's mostly useful for is to see if there's disease in the lymph nodes. So, for example, so this is a prostate cancer, which is a bit more advanced. We can see, if you look at the bottom left, there is a big, large actually right pelvic lymph node. And you can see that there's other lymph nodes which are highlighted on the upper part of the screen, we're looking at
excuse me, doctor. That's a slice, isn't it?
Yes. So that's
we're talking about a CT scan, so it's a slice.
Yeah. So basically, CT means computed tomography, which doesn't help much, but basically, it's like if they took an X-ray, or they took a slice of you at every level going downwards. So from your head, well, I mean, this is obviously a abdominal abdo-pelvis scan. So from the top of the abdomen to the bottom of the pelvis, it's like there's superposed X-rays. So, well, with better imaging, but basically we can see everything that happens on a certain slice. And it also helps later on to assess response if you have, so, you know, if there's cancer, we treat it, see if it has gone away. So, and the previous picture was an MRI. For doctors, it helps to get a better idea of the disease within the prostate. And often, sometimes when we're deciding if it's between an intermediate, but we don't have that detail on a CT scan. So, so what are the treatment options? So there's plenty of treatment options for prostate cancer, and overall, it's fairly complicated depending on what disease stage you're at, and also patient factors and hospital factors as well. So I was just going to go over some of the treatments which are available. So treatment choice depends on cancer severity, on stage, also on values, preferences, your starting functional status, and you know, expected side effects from the treatment, and also life expectancy. Because when we do a treatment, you know, we want the treatment to be beneficial, and we don't want it to cause more trouble than it should. So for very low risk prostate cancers, the standard nowadays is active surveillance. This goes for low risk and sometimes what we call favorable intermediate. In this situation, we don't actually treat the cancer because we consider, for example, if it's a low risk cancer, it's unlikely to progress. So in those situations, we may sometimes recommend active surveillance, and the benefit of that is we avoid the side effects of any possible treatment, all the while monitoring the prostate cancer before it can spread further and intervene if needed. What that entails is usually doing regular rectal exams. You have periodic visits with your doctor. You'll have periodic PSA testing. You'll have initially an MRI, and then less frequently, and you can have biopsies fairly regularly. Well, at least every 1 to 2 years to make sure that nothing is progressing. Another option is surgery. So basically, prostatectomy nowadays. So robotic surgery is a good option, and as opposed to the other option of laparoscopic surgery, where basically the surgeon is holding the instruments. The benefit with the robot is mostly that the surgeon's at a console, and it's robotic arms which are moving the instruments. As such, sometimes you have more degrees of freedom the robot can do maneuvers which the surgeon can't. For example, like turning if you're suturing, it can do a continuous turn, whereas human wrist can't do that. But so far, so that's what they're looking at with robotic surgery. And for so other options probably laparoscopic, where basically the surgeon is using the instruments to dissect planes and get the prostate out of there, but they go through holes which are placed in the abdomen. The goal of this is to try to minimize problems after the surgery and optimize recovery.
How does that compare to robotic?
So you would think that there would be like a huge advantage for robotic, but the studies so far haven't really proven it. The only advantage maybe in duration sometimes of post-op recovery, but overall they're like, for example, the surgeons would tell you that they feel that it's better because they have better visualization and they have more degrees of freedom. It's just that the studies haven't proven the benefit of this yet, but I would think that it's probably better because they're the ones who are doing it. You could definitely see better. You have a lot better vision compared to when you're doing it laparoscopically. So. But I'm sure like future trials will show there's definite benefit. So external beam radiotherapy is what we do as radiation oncologists. When you get radiation, basically, as some of you might know, you're lying on a table, and there's this machine which is over you. It aims basically in the situation of the prostate, or sometimes the area where the prostate was before. Radiation is given in small doses, a small dose every day, and classic treatments can be fairly long. Sometimes it could be 38 treatments, but there has been an ongoing push and new studies which have tried to reduce the duration of radiation treatments. So now we try to, new studies have shown that in some situations we can treat with 20 treatments, and we're doing a near trial which will show that for high risk we can do it in 25 as opposed to 38. So these are all pluses.
Sorry, that's the frequency, but the duration, how long does it take?
So each treatment's about 15 minutes or so. It doesn't take that long. The time that the actual beam is on is only a few minutes. Most of the time is to get you in the right position, make sure the bladder and the rectum filling is about the same, because radiation is very precise. Before we treat you, every time we're making sure that everything's in the right position. When you get treated, basically there's lasers and you have some markers on you, which also help align patients before every treatment. So I'd say maybe over the past 20 years, there's been huge changes in terms of precision with radiation. So basically, everything is the CT based kind of load. So we're making sure that the dose is always going to the right areas when we're treating. So that's basically it for external beam. Another way of giving radiation is brachytherapy. So brachytherapy basically is what we call internal radiation. We basically put needles inside the prostate and treat the prostate by doing this. There's different ways of giving brachytherapy. Sometimes we can put the radioactive seed directly into the prostate. which helps kill the cancer. Otherwise, we put catheters or needles inside the prostate and put only one high dose source, which runs through the needles and delivers the dose. When we give brachytherapy, usually it's 1 or 2 treatments. It's a procedure, so you're in a kind of a small operating suite. You're usually under sedation, so either general or spinal, and basically, so you don't feel your legs, you don't feel any of your lower area, so you're under anesthesia, and usually once everything is in place, we'll, depending if it's a high dose source, we'll do the treatment. Maybe also is that the beams don't have to go through your whole body to get to the prostate, because basically when we're putting the needles, the dose comes out from basically every point in the needle. So in some ways, the surrounding dose can be decreased. So how does radiation work? So either way, radiation is high energy X-rays. When it's in the machine that we saw earlier, what happens is there's like a beam of electrons which hits a target and releases high energy X-rays. And basically we direct these X-rays at the cancer and it damages the DNA. When we do brachytherapy, it's similar in the sense that the radioactivity comes out from a source or from seeds, and it releases high energy particles which destroy the DNA. And once the cancer cells have their DNA damaged, we give a dose which is sufficient to kill those cells. And some of those cells will die right away, and some of those cells will die over time, but they won't be able to replicate normally anymore. So that's why sometimes when you see your PSA going down, it doesn't always go down right away, but it can go down over time. And the important thing is that it stays low after the treatment. Now, if you have more, when you have a prostate cancer, which is more advanced, once we're at intermediate or high risk, we often add androgen deprivation therapy. Those are the injections which some of you may have received. What the injections do is they block testosterone, and testosterone plays an important role in in all men for a lot of important functions, from basically just maintaining your blood supply, sex drive, also maintaining muscles and energy. It plays a role in metabolism. But when we deal with prostate cancer early on, unfortunately, testosterone tends to stimulate those cancer cells. So when we block testosterone, often the cancer cells which have receptors to testosterone start dying. It blocks cancer cell growth, sometimes it puts them to sleep, and some of the cells just die. Also, when we give it with radiation, sometimes there's a synergy, and we have better cancer cell killing. So we kind of went over all the different types of, or a bunch of different types of treatments. When you have a low-risk prostate cancer, what we usually recommend is active surveillance. But other options are surgery, radiotherapy, either the external beam or brachytherapy. For intermediate risk, so sometimes we can do active surveillance, but it's probably not the best treatment, because once it's intermediate risk, Usually, we want to try to get rid of the cancer at that point. Other options are surgery, or we can do radiotherapy, either in the form of external beam, brachytherapy, or a combination of both. If there's more aggressive features, sometimes we add androgen deprivation therapy in the form of injections, but usually that's for 4 to 6 months, so we would say it's a short-term duration. And when we have high-risk prostate cancer, options are surgery again. So it might not always be the best option. Then we can otherwise do external beam with the hormones, or a combination of external beam, brachytherapy, and hormones. In this situation, ADT lasts for usually 18 to 24 months. And there's always clinical trials which are interesting because sometimes when we do phase 3 trials, we add additional drugs which we think are likely to benefit, and sometimes we don't always have access to them otherwise. So those are always interesting. Now, once you've had all these treatments, sometimes, unfortunately, the cancer can recur. There's different options depending on the recurrence and where it recurs, but for example, if you had surgery before, sometimes we can salvage with radiotherapy. If you had radiotherapy before, sometimes we can do surgery, or we can even do brachytherapy. If other options are cryotherapy, which is basically kind of freezing and thawing cells, or HIFU, which is high intensity focused ultrasound. So lately, PSMA PET is an interesting option as well for patients who have potential recurrences. It's a test which is more sensitive than other tests we use, like bone scans or CT scans by themselves. The way PSMA PET works is basically you have a CT scan, but we're also injecting so we're also injecting a radioactive product which binds to cells which have PSMA. So what that means is when you have cancer cells originate from the prostate, even if they've gone to the bone or gone to the lung or into the lymph node. So they still have the makeup of a prostate cell, and the PSMA can kind of attach to similar cells and light up and sometimes help us identify where a disease has recurred. So when cancer recurs, sometimes we can't find it, but sometimes we can. And if cancer recurs distantly, it means that it becomes a stage 4 cancer, and sometimes we can't cure it. But when cancer recurs only in a few areas, there's been ongoing research to try to treat that and hopefully cure that. PSMA PET can help us identify some of those lesions, and then there's ongoing research into trying to target those areas with surgery or other types of focused radiotherapy. And in the last 5 to 10 years, there's been a lot more research into new systemic therapies and trying to combine those with new forms of radiotherapy in the setting. So far, it's improved things a lot. And finally, so if the cancer gets more advanced, regardless of the cancer, it's never good. But for prostate cancer, we have a lot of options. So those options range from basically second-line hormone therapy like lutamide, enzalutamide, or lutamide. There's immunotherapies such as cycloocil T or pembrolizumab, and basically there's other treatments which, for example, can target a disease in the bone, like alpha-RAD. But it kind of gets more and more complicated once you have more advanced disease. But the takeaway message basically should be that there's lots of ongoing options, lots of clinical trials, and with prostate cancer, compared to some other cancers, we have more leeway in the sense that usually the disease, even when it's more advanced, progresses slower than some other cancers in an advanced stage and responds to different types of treatments. So I think there's a lot of promise in this area. That's it.
I have a quick question.
Sure.
In medical school, first of all, who comes up with these names? And secondly, do they teach you in medical school how to pronounce them?
No. So, like, a lot of these come after medical school, and they're constantly inventing new drugs and coming up with new names. So, sure.
About 15 years ago, I had laparoscopic surgery. Dr. Steinberg removed the prostate, and everything was good for a while. And the PSA started to go up, and it's about 1.60 now. And he's referred me to Dr. Niazi.
Okay. So,
and I'll be doing the PSA in the next couple of days.
Good. Well, I'm sorry to hear that the PSA has been rising, but so when you have surgery and they take out the prostate, basically you're taking out the prostate cancer and all the prostate cells. So we expect the PSA to be 0 after. So
it was 0.
Yeah. So when cancer, when what we call biochemical failure after surgery is once the PSA goes over 0.2. So as soon as it's over that number, we know that it's already too high, because normally you shouldn't have any prostate cells left behind. So as it rises, then basically we can try to detect where the cancer is. And well, you'll see Dr. Niazi, and they'll see if they're where the cancer is with the tests, and then try to treat it.
Dr. Steinberg, and they're both going to get the PSA result.
So they look at the PSA, and then the next steps would probably to do staging scans, and then decide what to do after that.
Thank you.
Sure.
So like the follow-up on this, if it's sort of decided that you're going to have the hormonal treatment with the radiation treatment, whether it's 20 treatments or 35, what is the wait for giving the hormonal shot?
So,
because it's 2 to 3 months after you get the hormonal shot until you start radiation. So while they're deciding what to do with the radiation, why don't we just give you the hormone shot so you're on your way?
So it depends. So if I understand your question well, it's basically if we. So what is your question? Sorry.
I was trying to generalize it. Okay, I hit 0.20. Well, I hit 0.27 this past summer. Okay, I've had the bone scan. I've had a CT scan. That's a month.
And did you have a prostatectomy first?
I've had the surgery. I've had removed.
Okay.
8 years ago. It was 4 years, sort of in the same situation. It was 0, and it sort of very gradually went up over 4 years. I was at a 0.3, hit 0.17, and the last one between in a 3-month period went from 0.17 to 0.26. Okay. So I'm listing the risk in that, and possibly going to the 20 procedure. I signed on to the study. But I wonder when the wait is to do the hormone shot.
So it depends.
Once you've done scans in that, what's the hold up? The shot should almost be automatic, I would think. There's the possibility you wouldn't
the higher the number is, the more likely you're to find something on the PSMA PET. Because say if you do a PSMA PET and it's negative, then the question is, if the value is too low, maybe there's benefit in repeating a PSMA PET again. But this area becomes a bit controversial because PSMA PETs are not exactly standard right now in terms of options for prostate cancer. So it should be, and it probably will be. But to get a PSMA PET now, it kind of depends, and it depends also if you're in some studies. But were they thinking of doing a PSMA
No,
PET?
that's what I'm saying. I've not heard bone scan, which is like a month now.
Okay.
And that's why I'm just wondering, like, if it's been decided you're going for the hormone and radiation, why would they not just do the hormone shot?
So basically, once
You know,
once staging is done, once you had all the results of your tests, basically they could start it.
you know, that's what I'm.
Maybe what the problem is, the wait line for the whole,
Maybe.
for the radiation too. Because that's a piece of equipment.
Yeah.
It's not like, so that might be part of
Yeah.
the problem in the future.
Okay.
I also think you talked about the synergy.
Mhm.
When I had my treatment, the strategy was at that time was to slow down, weaken the cancer cells,
Mhm.
Yeah.
hormone treatment, and when they're like flopping around, then the
Yeah.
radiation after.
And yeah, because once
Well, that's what I understand, but that's why I'm wondering why because there's that time period for this punch out, as you would say,
3 months was him.
that why don't they do, as soon as they've done your staging test, why don't they do the hormone shot?
so some people do.
That's weird,
Because he wants hormone shot.
Well, I don't disagree with you. If they're done with all the staging and if say they've decided on treatment, if it's either hormone shots or hormone and radiation, or there isn't any, you could always ask your treating physician.
Maybe in 6 months would change your mind on the side
Listen,
effects
I get very bitchy.
hormone therapy. We'll see.
You know, are there any questions from the Zoom?
Not so far.
Thank you.
Oh, no worries.
External radiation.
Mhm.
with hormone treatments. And I have developed, after about 9 months after the treatments, there's some radiation hepatitis
Mm.
with the bleeding. With treatments on that, how long would that last? Before,
Have you had any treatments for it so far?
I've had, yeah, some treatments, but
They did a colonoscopy.
not yet. I've
Okay.
had one requested in June, and I'm still waiting.
So basically, when you get external beam and we're giving the radiation, sometimes, well, the prostate is like a ball, and the rectum can be right behind. So sometimes part of the beam, well, there's always some dose which is going to the rectum, and that's always verified. But from one person to another, sometimes you can just react differently, and an area can react differently too. And sometimes, basically, when you have radiation fructitis, the vessels along the rectal wall become a bit more friable. And what happens is when you're passing stool, it rubs against that area, and then it can start bleeding a bit. And sometimes it could bleed a lot. And so what we do, if that happens, is basically we refer you to the gastroenterologist. They'll do a colonoscopy, and they'll actually visualize that area. On the report, you could probably even see, like they'll say, this area, there's been radiation changes or damages. And then the treatment for that after, basically, there's different things. They can give you some creams. Sometimes it can be steroids, or sometimes when they do the colonoscopy, they can do a treatment called argon plasma coagulation, which is basically they'll see the area which is abnormal, and they'll basically pass a type of gas, argon plasma, which will basically stop that. So
Sorry, would it be important for allow him to change his diet as well? Would that be helpful?
So sometimes there were some studies which looked at like short fatty. I'm not sure how long the benefit. It might be easier to just have the colonoscopy and they treat that area. But what can help is maybe in terms of diet, avoid stuff which can make you more constipated. Gonna help, and it's gonna make you bleed, and that's what we want to avoid. Pending you see the gastro.
Sorry. We have a question on the microphone. Mario, go ahead.
Yeah, hi. Thank you for I'm on the phone here. I have a question about Pluvicto, the new drug that was approved early September.
What's it called?
Pluvicto, Pluvicto.
Okay. I'm not.
And it's typical, like I don't know how it works, but sort of like it tries to isolate the cancer cells and it gives it radiation. So I'm thinking it's probably an injection, like I've never had hormone therapy yet, so I'm not sure how that'll work. But basically what it is, I'm not eligible for radiation because 23 years ago, I had rectal cancer. At that time, I had surgery, and then in between my chemo, I had radiation for 4 days. So in 2020 of July, I had prostate cancer. So they went and they had surgery to remove my prostate. But then a year later, in September of 2021, the cancer came back. And so my oncologist sent me to radiation to see if we can do radiation and hormone therapy. And they said no. Because of the radiation 23 years ago, it would be too dangerous to try to radiate again because the bladder and the rectum are very close to each other.
How many treatments of radiation did you get initially?
That was 23 years ago.
And how many at the time did they give you? Was it like 20 or
4 days?
4 days?
It was about maybe 1 hour, or I don't know how long it was, maybe a half an hour for 4 days. Like we started the chemo, and then we started the chemo in April, and then in July we stopped the chemo for 4 days. Around the middle of July, we stopped the chemo for 4 days, and we did radiation for 4 days. And then the last day, we started back with radiation and chemo until October.
So basically, the things that limit radiation is the dose that the tissues get. So normally, the dose that like the rectum. So we when we treat with radiation, standard fractionations, what we call 2 gray per fraction, that's basically when you get those small doses of radiation every day, you basically get 2. So to not be able to get more radiation in an area, usually you would have had to have received a substantial amount. If you go beyond that dose, then we can give more radiation. But if it was below that amount, then if you got like a few treatments of radiation, and if the dose wasn't that high, usually we would still be able to give more dose until we reach the tolerance of the organs at risk surrounding it. But it's hard to say without knowing your whole file and knowing exactly what dose you got and why they decided not to. But usually your treating physician will will decide that based on all the information that he has.
It sounds like the.
Okay, and this new drug that was approved back in September, you're not too familiar with it then?
No, I'm not. But it would be odd that if usually we don't really give radiation by pills. Sometimes there's some treatments like radium-223, which is given IV, which is basically a radioactive particle which goes to the bones and treats cancer there. But I'm not familiar with anything in the form of pills.
All right, thank you.
Yeah, sorry about that.
There's new,
No problem.
Yeah. Mm.
How soon
Mm.
come out from the States to be available for doctors such as yourself to use or down in Europe?
So it's always a bit complicated because now there's a whole bunch of there's hundreds and hundreds of treatments, and all trials start with basically phase 1 trials. There's a whole ladder that a treatment has to climb before.
I'm not talking about theoretical possible. I'm talking about those that reach the highest levels and approved for usage.
So usually at that point, a trial has to go through a phase 3 trial, and that phase 3 trial has to show that there's a benefit. At that point, usually it gets approved by the FDA in the States, and Health Canada usually approves it here as well. Now, it all depends because in the States, if you have private insurance, there's, as long as it's safe and it's beneficial, it gets approved pretty quick. In Canada, sometimes you have to take into cost the financial burden as well. But usually, it's very variable from one drug to another. Sometimes, like in Quebec, you can ask if there's proven benefit. You can ask for some drugs as a exception drug.
Let me be more clear. I'm not specifically talking about a medication. I'm talking about a form of treatment, which is not.
Which treatment are you talking about?
For prostate cancer, for example, we have other new discoveries and procedures, surgical procedures or radiation procedures.
All the time, there's phase 3 trials which are constantly running.
How soon does it get into your hands? Really, there's so many.
Each treatment would vary, right? For example, like for high-risk prostate cancer, there's a trial which is going to be presented like in the next few months. Which might maybe do 25. Once that is presented and accepted, then we can start using it more frequently in clinic. So, for example, that's a radiation technique. It doesn't have to go through the FDA or Health Canada. For radiation, it's more a question of can we feasibly do it? We'll look at it in what we call dosimetry with the physicists who help deliver the treatment. And then once we can do it, we do it. So for some things, it doesn't take a long time. As soon as we have proven data, we can implement it. But other things we can't. And if you need new materials or new equipment, it becomes harder too. For example, in the States, they use protons to treat prostate cancer. It's probably not the best use, but for pediatric malignancies, cancers in children, it has huge benefits, but the cost is enormous, like maybe 200 million for a facility. So we don't actually have any of those in Canada, even though it's been, like many years that, even more than a decade or two that has been discovered. So when we do need it, we send patients to the States to have it done.
I have a question here. One person wants to ask a question and another person wants to ask. I was wondering if cancer cells can escape the prostate during biopsy due to the puncture in the prostate wall.
So it's rare. Usually, I would say for the vast majority, we don't see it. So in some cancers, it's very frequent. Like there's a cancer of the muscles, which is called a sarcoma. If you do any type of biopsy in that, the tract basically seeds, and then that's not good. So basically, when they resect or remove that cancer, they cut the whole tract out, and they basically we irradiate that whole area as well. For prostate, it's very rare. In terms of seeding, it's probably under like 0.5%. And even then, extremely rare. So usually it's not too much of a worry.
So that, we're talking about the rectum and the bladder and stuff like that. What do you think about for the one that will have radiation, the little biological gel or whatever?
Yeah, the
space like
space or
push the away so we can avoid the kind of
bit of an invasive procedure. It's kind of like it's not that bad actually. Basically, you're putting an injection, and it's kind of like a gel which kind of solidifies. They use it more maybe for brachytherapy in some centers, not so much in Canada, but it can definitely have benefits because basically when we treat with radiation, we know where our dose is falling off. And if you put the fall off in the spacer, then it's not falling off in the rectal tissue. So it can be beneficial.
One of my doctors mentioned that it's hard. You don't exactly know when you're just going in the right place. You don't know if these spacers that it doesn't actually get in the place you want it to get.
Yeah, because basically you're kind of injecting it, but you know where you know that there's a space between tissue planes, and basically when you put the needle, it falls in that empty space, and it's supposed to cover that area, but it's not like probably not 100% effective, but I haven't, and it's not covered now, I don't think.
Isn't that radiation partly is the fact that the space or is not covered under the medical system? Isn't that part of it?
Yeah, so probably coverage on one end and just expertise also, like just people using it in general.
I have another. Andrew, you have a question?
Hi, can you hear me okay?
Yeah.
Okay, good. Hi, thanks for attending, Doctor. Thanks for sharing all your information and knowledge with us. I do have, I guess, a bit of a comment and a question. I'm currently, just to summarize my current situation, is I'm at the Glen right now and I'm undergoing hormone and radiation external beam therapy due to recurrence of prostate cancer. Last year, around September, I had my prostate removed. but then a few months later, the PSA started to go back up again. So when I spoke with the oncologist at the Glen, Dr. Curry, and he recommended this therapy treatment to try and eliminate the cancer. So I guess the comment I have, I guess, for the other person that was asking about their hormone shot and then starting the radiation, I was told that it takes 2 or 3 months for the hormone shot to fully take effect. It's not immediate. It takes a while before your testosterone gets down to 0, and then they start the radiation. That was my understanding. So I'm not sure if that's correct or not.
Well, sort of, in the sense that your testosterone goes down pretty quickly because initially well, there's always a bit of a lag, but in addition to getting the injection, you're also getting a pill. Usually you're getting Casodex or bicalutamide for 7 to 14 days. I mean, it'll still take a little while, but usually it's not like, it's not going to take 3 months for the PSA for the testosterone to drop fully. But the idea for delaying the radiation is basically when you're giving the hormone treatment, you're also kind of sensitizing the cells to the drug, and the cells are dying also from the blockage of testosterone. So putting the cells in that state, we think sometimes it could be more beneficial. But some studies have, in some situations, at some centers, they don't always necessarily do what we call neoadjuvant hormone therapy, where you wait that delay. But the theory why we wait is to try to kind of sensitize the cells and try to get a more synergistic reaction once we start the radiation.
Sure. I'm part of a study that I get 2 shots of the Eligard hormone shot, and then the radiation. So I had the first shot in June, and I had the second shot just before.
Anything else? Any other question? Did you have another question? Is there anybody else who would like to, I know it's late for you, right?
Oh, no, it's
You're
fine.
okay, you're okay?
Yeah, feel free.
Does anybody have
please
any
feel
other
free.
questions in the room for the doctor? Frank, you have something?
One question. If you've had radiation therapy and you get it and it does come back, then they look at the actual removal of the prostate.
Yeah, so
Why not? My question is then why not? Why cannot add more radiation therapy?
so it depends. When we give external beam, the dose we're giving you, we don't want the cancer to come back initially. So when we're giving you a dose, it's the maximum dose we can give you. I mean, so basically, once that dose is given, over time, some of the tissues will recover to some extent. But given that you've got that maximum dose, we can't really give more. But in some situations, for example, say if you get external beam, and say there's a recurrence in the prostate, in some situations we can treat with brachytherapy if we treat a limited area within the prostate. But there's increased risk of complications because the risk of complications is basically a probability curve. So the higher you go in some with the dose, the likelihood of developing severe complications can be higher. So that's why we're careful with that.
You would treat the cancer cells at the expense of complications.
Well, I mean, we're treating the cancer cells is within normal prostate tissue. So, I mean, like any cancer, basically you have cancer within a normal tissue. So you always have to take account of the surrounding normal tissue.
Did that answer your question, Frank? Excellent. Are there any other questions in the room? You're okay, Marlon? You have nothing else, or you're ready to change your diet? Just kidding.
This too will pass.
Yeah, it sure will. I'm sure pass in many ways, I'm sure. Yeah. Well, I want to thank you so much for being here tonight. It's been very informative for myself and for the guys, and nice to get some personalized, direct, free consulting, right? So, yeah, thank you guys. Thank you so much.